everyone, myself Dr. Akshat Jain, interventional cardiologist at Raipur, Chhattisgarh. So I will be showing one of the case that was really a difficult one and can be said or considered as a cardiologist's nightmare. So this is the patient details. He was a 44-year-old male, chronic smoker. He was referred from a peripheral center in cardiac ambulance on non-invasive ventilator and dual inotropic support. Had a history of anterior wall MI 2 days back and he was lysed, but it was a failed lysis. Vitals showed tachycardia, BP on inotropic supports, heart sounds were soft, there were bilateral creps on respiratory examination, saturation was maintained but on 60% FiO2 with an IV support. This was a patient's ECG. The ST elevation in AVR more than V1 made us aware that there could be a possibility of left main or left main equivalent. And echo was showing mainly the hypokinesia and LAD territory, and fortunately the thickness was preserved and the ejection fraction was 30%. Biochemistry, hemoglobin and creatinine was normal, but there was severe elevation in LDL of 164 mg per deciliter and also of serum lactate. So this was the angiography. As you can see here that there was a total left main occlusion. We confirmed it on the cuspal shoot as well, and then we were like, okay, so what next? So we just wanted to confirm about the viability. So we just, instead of sending the patient to MRI or PET, as this is a case of more than 48 hours, we chose to do a right shoot. The right coronary showed a very good collaterals to the left system, which is one of the proof of viability. So there was a borderline lesion in right, but definitely this left system was the acute and the culprits, so we decided to go ahead with the left angioplasty. We kept both the guide in RC and LM to make sure that if required we'll do the dual injection if there was some problem during the wiring. We wired LM to LAD. We positioned LM to LAD stent as there was some flow after the wiring, and we were most likely that this was a thrombotic blockage. So we positioned the stent and then we released the stent. We released the stent just across the septum, the distal part, because in the retrograde shoot that this was the healthy zone. We confirmed the caudal shoots without wire, and fortunately no side branch ramus or L6 was disturbed, and TB3 flow was achieved in all these coronaries. So post PCI phase is also equally important. The continuous monitoring of vitals, input, output, EBG, including lactate levels are crucial to understand the hemodynamic shift of the patient. Patient was weaned off slowly over 48 hours. He was extubated after 36 hours of the index procedure when his inotropes requirement was decreased, and was discharged after 5 days happy and alive. And this was the ECG at the time of discharge. This is the QS in V1 and V2, and rest all territories are showing good R wave. So what better could have been done is we could have staged a second procedure to optimize LM-LAD stent using imaging, and could have done FFR2RC for a borderline lesion that we could have seen to check if that was significant. We could have used circulatory support, but again the cost is inhibitory here. The cost of impaling is around 17 lakhs and IBP is around 1.5 to 2 lakhs. So many patients cannot afford it. TPI could have been kept in IVC instead of RV to avoid the risk of perforations, and balloon tip TPI could have been used instead of conventional tip TPI. So these are the take-home points. In an acute left main occlusion, time is muscle and life. Survival of the patient is the proof of viability in left main occlusion. One should not waste precious minutes in assessing the viability of the target territory. In spite of all supports, risk of peri-Puri's procedural mortality is high in acute MI with cardiogenic shock and heart failure. If there is good retrograde filling, dual simultaneous angiography can help guide wiring even in acute setting. Keep all your supports TPI, IBP, impella, ventilator, anesthesia ready and stand by. Minimal procedure time is the key to avoid hemodynamic deterioration. LM to LAD wiring and stenting is the priority. LCX is to be tackled as a second priority. Lesions in young patients are usually thrombotic. Wiring is usually not difficult. Left main stent optimization is must in same setting or in staged manner. Final outcome requires coordinated and dedicated team support, which includes interventional cardiologists, intensivists, anesthesiologists, and definitely a good nursing and care staff. Thank you.